Medial shoulder instability, or MSI, is a common cause of shoulder pain and lameness. We know from the name that this is a condition that affects the medial, or inside of the shoulder, and involves failure in the stabilizing tissues. So this is essentially the equivalent of a rotator cuff injury in humans. Let's look at the relevant and affected structures. So here we have the medial side of the right forelimb of the dog, medial scapula, medial humerus. In this drawing, the humerus is slightly externally rotated. Here we have the medial glenohumeral ligament and the biceps brachii tendon of origin coming off supraglenoid tubercle. Coming down here, you can see the biceps brachii muscle belly, just to give us some additional reference. So the shoulder joint in the dog is a ball and socket joint. The head of the humerus here, the arm bone, makes up the ball, and the glenoid cup or cavity here on the scapula is the socket. The head of the humerus is much larger than the glenoid cup though, and this makes it what we call an incongruent joint, meaning the two pieces don't fit perfectly together. The large ball, the humeral head, this shallow socket here on the scapula, allows for more mobility. Actually the greatest range of motion of any joint in the dog's body, but this comes at the cost of bony stability. Every joint must have a balance between mobility and stability. The hip favors stability and the shoulder favors mobility. So this is an inherently mobile but unstable joint. Of course, the bones, the scapula, and the humerus are only one part of the joint. Today we'll be looking at the medial side of the joint only. The shoulder is held together by passive and dynamic stabilizers. Damage to some or all of these structures could result in medial shoulder instability. That's why you might often hear medial shoulder instability referred to as a wastebasket diagnosis, because it isn't really specific and refers to the symptom rather than the exact injury. In the shoulder, there are two main passive stabilizers. The first is the medial glenohumeral ligament here, depicted in either a Y or trident shape. I've gone with the trident shape here. It comes off of the distal scapula and goes down to the lesser tubercle on the humerus. There's a cranial arm here and a caudal arm here, and as they move distally toward the humerus, they join together prior to inserting on the humerus. This is a relatively weak ligament that is commonly affected in medial shoulder instability. Even in healthy dogs, this ligament relies heavily on support from other stabilizers. The medial glenohumeral ligament depicted here is actually inside and a part of the second passive stabilizer we're going to talk about, which is the joint capsule. The joint capsule, we'll look at that here on this depiction of the left medial side of the forelimb of the dog. The joint capsule here starts from the outside of the glenoid cavity and goes down and attaches just below the articular part of the humeral head. There it blends into the periosteum on the neck of the humerus and surrounds, as you can see here, the biceps brachii tendon inside the intertubercular groove between the greater and lesser tubercles. Inside this joint capsule, synovial fluid fills the joint space to reduce friction and keep the tissues healthy. A balance between synovial fluid production and absorption must be maintained to achieve the correct interstitial fluid pressure, sometimes called IFP. Having the correct interstitial fluid pressure keeps the joint healthy by distributing forces evenly across the joint. If you don't have enough synovial fluid, that can lead to weight not being evenly dispersed. Too much could lead to excessive pressure and pain in the joint. If you think of someone with a swollen knee, then maybe needs to go to the doctor to get some of that synovial fluid drained out to alleviate the pressure. The main dynamic stabilizer is the subscapularis tendon. So we'll look here at the subscapularis muscle here, up here. It originates from and occupies the subscapular fossa on the scapula here on the medial side. It slightly overlaps the boundaries, both cranially and caudally. It's a relatively flat muscle that's divided into a few sections by tendinous bands you can see depicted here. It crosses over the shoulder joint and the medial glenohumeral ligament, inserting into the lesser tubercle by a short, thick tendon here, uniting with the joint capsule. This serves a few functions. First, it allows the joint capsule and the subscapularis tendon to insert into the same area, meaning they merge so they can share the same area that they're inserting into. Also, having an insertion point for a muscle near the joint increases the speed at which they can move the joint. So both structures fusing together allows them to share preferential space on the bone. Here we have the right forelimb of the dog, and if we look here on the medial side, using the example we looked at earlier of the biceps brachii muscle coming here through the intertubercular groove, the biceps inserts here on the radius and the ulna, quite close to the elbow joint, the joint on which it acts on. And we can think about why that might be. One, if the muscle was inserting down here, it would be biomechanically quite awkward to have essentially a triangle of muscle on the front arm of the dog. But primarily, the reason why muscles want to insert right after the joint on which they exert their main action on is speed. And so biceps coming down here, inserting here, when that muscle activates, it's going to be able to move the joint very quickly. The further it moves distally down the race and ulna, the slower that reaction would be. Highly mobile joints, like the shoulder joint, need a certain degree of laxity inside the joint capsule. So we'll go back and look at the joint capsule again. This increased laxity does increase the risk of the joint capsule getting pinched within the joint. So when this tendon of the subscapularis muscle and the joint capsule merge together, this actually decreases the risk of capsular entrapment, and it easily allows the muscle to compress and tense the capsule. Meaning, this subscapularis muscle is exerting action on the joint capsule underneath it, so it is compressing, tensing that capsule, increasing stability of the capsule by doing so. Keep in mind that while this tendon does insert and merge into the joint capsule here, a muscle can pass over a joint capsule, not attach into it, and still contract and press on the joint capsule and exert action on it without being fused into it. So the subscapularis tendon functions like a medial collateral ligament for the shoulder. Again, activation of this muscle compresses the joint capsule, creating dynamic stability. In addition to its action as a stabilizer, though, it also works to extend the shoulder. So contraction of the subscapularis muscle here will extend the shoulder. It also plays a role in contributing to maintaining shoulder flexion, meaning when the shoulder is already flexed, the subscapularis will play a small role in helping keep it there. It also aids in adduction of the shoulder, so it's going to be adducting, moving the forelimb toward the body, and also internal rotation. So internal rotation of the humerus is going to be played a small role by the subscapularis muscle. It's innervated by the subscapular nerve and the auxiliary nerve. It's bordered by the supraspinatus here, cranially, which we'll talk about a little bit more, and the teres major behind it here caudally. Some sources will say that injury to the subscapularis tendon is the most common component of medial shoulder instability, while others will say it's the medial glenohumeral ligament. Both are very important medial stabilizers that can be injured, resulting in medial shoulder instability. Severe medial shoulder instability, though, will generally involve injury to both. And it seems rational that a chronic injury to one, if left untreated long enough, will result in injury to the other, as it will be overloaded trying to compensate. Cutting of the subscapularis tendon in cadavers did result in creating medial shoulder instability. Cutting the cranial band of the medial glenohumeral ligament here did not result in instability right away. It was the inflammatory response weeks later that resulted in medial shoulder instability. So the injury still resulted in medial shoulder instability, but it did take longer when just a part of the tendon was injured. So that's something to keep in mind when it comes to diagnosing. There are two ways that medial shoulder instability can develop. A chronic or repetitive injury is when the dog has overloaded the affective tissue via small repeated traumas until one day the medial glenohumeral ligament or the subscapularis tendon or the joint capsule suddenly fails during the course of normal daily activities like jumping off the couch or doing agility courses like weave pulls that they normally do, a minor slip on the floor, things like that. A traumatic injury is what it sounds like, a sudden injury resulting from a significant overload of the tissues, an accident, a bad slip fall, something outside of the norm that dog would be performing in, type of strain they would be putting those tissues under. If there is muscle atrophy in this area or damage to some of the other surrounding muscles, that can put more load on the subscapularis tendon and the medial glenohumeral ligament and increase the risk for injury. Congenital abnormalities in either the scapula or the humerus could also result in medial shoulder instability. If the glenoid cup here lacks concavity, doesn't have enough curve to it, and isn't very much of a cup, it's too flat, or if the proximal humerus here is misshapen in some way, then that dog will be at a much higher risk for developing medial shoulder instability, because this already incongruent joint is just going to be fitting even worse together. Muscles and ligaments will have to work much harder to compensate for these bony defects. Smaller breed dogs are more prone to these birth defects, much like we see with patellar luxation. Their muscles will have to work much harder to compensate for this decrease in bony stability. Regardless of whether the injury is chronic or traumatic, the injury is due to excessive abduction. the arm moving too far away from the body under too much strain. The medial glenohumeral ligament and subscapularis tendon on the inside of the shoulder joint both limit excessive abduction. When these structures are put under heavy load, whether from a slip, weave pull, or any other cause, sudden or progressive failure can occur. Medial shoulder instability most commonly affects agility in working dogs from 4 to 5 years old. These are dogs who run hard and put these relatively weak structures under heavy and consistent load. Interestingly, poodles are also overrepresented in medial shoulder instability injuries. They seem to have some genetic propensity to this injury that affects purebred and 50% poodle crosses as well. It isn't clear the exact reason. The main two variables in joint instability are joint anatomy and soft tissue laxity, so it would likely be either one of these two or a combination of both. But whatever the cause, the numbers in one Australian study were very decisive. Poodles were represented over 13 times in medial shoulder instability. So medial shoulder instability should probably be considered in any poodle showing forelimb lameness. In other breeds, about 4 to 5% of forelimb lameness is medial shoulder instability. It is the most common cause of shoulder instability. About 60 to 40% of shoulder instability cases are medial shoulder instability. Most of the remainder are lateral. Cranial and caudal instability are very rare and generally result from some sort of trauma. So there are 4 grades of medial shoulder instability. A grade 1 is a mild medial shoulder instability. That's where there is inflammation or laxity in the medial glenohumeral ligament or subscapularis tendon, but there's no fraying and there's no tears. In grade 2, a moderate medial shoulder instability, this is the most common type. This could involve fraying or partial tears, but not a full tear of either the medial glenohumeral ligament or the subscapularis tendon. More than half the time, there's also concurrent supraspinatus tendinopathy, according to one source anyway. In grade 3, severe medial shoulder instability, that's when there's a complete tear to the subscapularis tendon or medial glenohumeral ligament, so completely torn, or to both of those structures, a complete tear. This is much less common and obviously a very severe injury that's usually the result of trauma. In grade 4, that's luxation. That's when there's a complete tear of the medial glenohumeral ligament, a complete tear of the subscapularis tendon, and that has led to complete displacement of the humeral head. So, humeral head out of the socket. If the injury is mild, symptoms could be subtle, such as a shortened stride, reduced shoulder extension, muscle atrophy, muscle spasms, or pain on abduction, moving the limb away from the body. If the injury is very serious, it could lead to something like full limb lameness on the affected limb. Lameness, if present, will typically be worse after exercise. Noticing these symptoms early and providing a correct diagnosis and treatment will stop this condition from progressively worsening, leading to further instability and the development and progression of osteoarthritis. Even though this condition is called medial shoulder instability, it does not always result in detectable instability. Some people have suggested the term medial shoulder syndrome is a more accurate description, but medial shoulder instability is still the predominant term. Assessment for medial shoulder instability will generally involve hands-on palpation and imaging. The most commonly performed test is an abduction test. There are 2 versions of this test, and ideally both will be performed and compared for the results. The first, the dog can be awake and standing, or laying down. So one forelimb here will be extended while the elbow is straight. The arm will then be put into abduction, moved away from the body here, moved up. In this case, the dog is laying down in lateral recumbency. This test can be done using a goniometer, like here. So you would put this goniometer across the spine of the scapula on one side and across the humerus on the other side, and then you would measure that angle as you abduct. Here, let's put it this way so you can see. So again, you would measure the angle from the spine of the scapula to the humerus as you abduct the arm away. And if you come up to here, that would be 30 degrees. So the shoulder joint will also generally be moved in circumduction with internal and external rotation to check for any subluxation, the humerus moving out of the socket. The primary goal of the awake test is really to evaluate for pain when doing these movements. The test can then be repeated when the dog is sedated on their side, and that will give you a more accurate abduction angle. When the dog is sedated, you also will have the active stabilizers like the supraspinatus tendon or supraspinatus muscle turn off because the dog is sedated. They won't fire as much as they normally would. And this is important because if there's injury to this medial glenohumeral ligament, but not to that subscapularis tendon, that muscle may be able to tense up and compensate for the dog when it's awake, leading to a normal abduction test in an injured dog. The average healthy dog will have an abduction angle of 30 degrees, as we looked at earlier. The average dog with medial shoulder instability will have an abduction angle of 50 to 55 degrees. However, this test is not definitive. Some dogs with medial shoulder instability will not have an increased abduction angle. There will be injury to the medial glenohumeral ligament and or the subscapularis tendon, but not so bad to lead to laxity in this test. Again, as we talked about earlier, muscle activation and guarding can also limit this abduction angle and skew the results of the test. Also, not all dogs with an abduction angle above 50 degrees will have medial shoulder instability either. Some dogs have been reported to have abduction angles up to 75 degrees in a healthy shoulder. Normal abduction angle will also vary within breeds. 45 degrees is a normal, healthy average in a sled dog, for example. So 45 degrees. So you might ask, why do this test at all then? And while it isn't conclusive, an abduction angle around 30 degrees still makes medial shoulder instability less likely, and above 50 degrees means it's more likely. So it can still inform which test to prioritize next. Also, both the affected arm and the healthy arm should be tested. If there is significant difference in abduction angles between the two arms, that would indicate a much higher likelihood that medial shoulder instability may be a contributing factor. An abduction angle difference of 15 degrees, so 15 degrees here, that much difference between the two arms is considered highly suggestive of medial shoulder instability, even if both angles are within the normal range. Or if there's any pain on abduction in this test, that's also a strong indicator of potential medial shoulder instability. If there is atrophy of the shoulder muscles, pain on palpation, notable spasms in the surrounding muscles, this again could also indicate medial shoulder instability. Also, while range of motion will generally be increased in abduction, range of motion in other directions, particularly in extension, will often be limited. Supraspinatus tendinopathy should also be tested by flexing the dog's shoulder, flexing the shoulder here, and palpating that tendon of insertion. MRI, ultrasound, or arthroscopy can be used to look at the tendons and ligaments for fraying or tearing. Because MRI is so expensive and requires full sedation, it's not commonly used. Ultrasound is very good for looking at tendons, muscles, and ligaments. However, it can be harder to see this medial side of the shoulder because it is, again, on the medial inside of the shoulder, so it's going to be harder to reach in there with ultrasound, especially if the dog is overweight. It can often be done with mild sedation or sometimes with no sedation, though, and it's generally available at most clinics. You can also do ultrasound dynamically, meaning you can move the dog's limb into abduction, extension, and you can do that with the ultrasound pressed up against the joint, and you can see what those structures look like while the dog is actually moving. Shoulder arthroscopy, though, is still considered the gold standard, and needle arthroscopy can be done under sedation to look at these muscles, tendons, and ligaments. We must also remember to rule out other issues, such as elbow pathology, shoulder osteochondrosis dissecans. If the dog has been lame on the front limb for a long time, they could also have disused atrophy of all the muscles around here that results in weakness of the stabilizing muscles, like the subscapularis, and therefore leads to laxity in the shoulder. This could result in an abnormal abduction angle. However, this laxity may not really be medial shoulder instability, or it may be very mild medial shoulder instability, but secondary to an earlier primary injury. This is why other imaging such as X-ray and CT scans may be used, not to diagnose medial shoulder instability, but to look for other injuries that could be causing or contributing to the medial shoulder instability related symptoms. You could also, of course, have multiple independent injuries as well. X-ray could also be used to diagnose a severe grade 4 medial shoulder instability, because again, remember, that is where there is luxation of the humeral head, and you can see the two bones being out of place, or the one bone being out of place in relation to the other on an X-ray. If the injury is severe and the articular cartilage is wearing, the head of the humerus is luxating, then surgery will often be recommended. Otherwise, conservative management is usually attempted first. Rest, rehab, pain management, shockwave, laser, platelet-rich plasma, stem cells, stretching, not abduction, obviously, massage, neuromuscular electrical stimulation to treat the muscle atrophy. Note, the teres major muscle coming behind here will often be very tight from trying to compensate in this condition, and massage and laser can be particularly beneficial there. The dog can then be reassessed after, say, 3 months to see what progress has been made, if any. Remeasuring and comparing these abduction angle tests can definitely help to monitor progress in the dog. Radiofrequency induced thermal capsulography is also used. You might see that abbreviated RITC. And this is an intermediate option that may be used to treat medial shoulder instability grades 1 and 2. It is used to heat up the tissues, and this heat applied here causes the collagen to contract and the ligament and/or joint capsule to shrink and tighten, therefore treating the laxity. In the past, they used to do multiple passes with the tool, but they found that overheated the tissues, resulting in damage. Now just one pass with this tool is the standard to adequately shrink the targeted tissues without damage. This won't work on grades 3 and 4, as again, grades 3 and 4 involve full tears, and drinking 2 ends of a cut rope isn't going to reattach them. But in grades 1 and 2, where there is laxity or partial tears, outcomes are pretty good, but the full healing benefits can take 6 months. This is an arthroscopic procedure, and it won't require a huge incision. For cases requiring full surgery, the canine tightrope system is often used. This is where holes are drilled in the bone, and then ropes are pulled through to tighten the joint down. You'll often see it in like a V shape here. These ropes are placed superficial to the joint capsule, meaning they're going to go over the joint capsule. The biceps and supraspinatus tendon transpositions are also used. So that's where they would move this tendon here more medially over the shoulder to try to replace some of the function of these structures that are damaged. In general, tendon transpositions tend to alter shoulder biomechanics though, because again, this bicep isn't designed for that function, and it's also performing its own function here. So anytime the biceps or supraspinatus is moved, they're now being asked to deviate from their natural movements, which will generally result in more degenerative changes over time. But either way, the goal is the same. It's to reconstruct a medial support here for the glenohumeral shoulder joint. This has been a fairly comprehensive overview of medial shoulder instability. If you like videos like this that cover conditions and the affected anatomy, let me know. Or if you prefer some of my other videos focusing on the anatomy of a single muscle, let me know that too. I'll continue to make both styles, and I'm going to be doing more drawing for workbooks on my own education. So hopefully you enjoyed this new format where I use some of my drawings to explain and go over the structures. I think they're a little bit more detailed than the whiteboard allows. And I'll definitely mix in some color drawings in the future as well. Thanks so much for watching.